I'm Barbara Tops. I'm 81 years old, and I struggle with heart failure and lung disease.
I'm Akane Tanaban. I'm 50 years old, and I suffer from chronic fatigue and low blood pressure.
Regardless of where you're from, regardless of your specialty or area of science, there's one thing each of us has in common: experience with adversity. You've just met Barbara and Akane. You'll soon learn more about their stories. Adversity is a state of persistent difficulty, calamity, or misfortune that affects one's ability to achieve various life goals, including health outcomes, well-being, and happiness. Well-being and happiness, isn't that something we'd all hope for? However, the reality is violence, racism, crime, natural disasters, COVID-19, and economic distress are examples of adversity across the globe. Today, I'm going to discuss with you how adversity translates into clinical medicine, the biology of adversity, and how economic adversity underpins it all. Let's start by taking a look at adversity by the numbers. Adversity is experienced across the life course, beginning in childhood as adverse childhood experiences, or ACEs. After many years of studying the question of how adversity translates into clinical medicine, I have developed an equation to help conceptualize the answer. On the left side, cardiovascular outcomes, or any clinical outcome, are grouped with well-being. But as we try to improve cardiovascular health outcomes and well-being, it is important to recognize the drivers on the right, where the deleterious effects of adversity, modified somewhat by resilience, are mainly counterbalanced by what I've termed wealth, plus traditional risk factors. In this context, wealth can be finances, social capital or support, or even joy. Wealth is the currency that can help counter the experience of adversity. This formula provides a way to understand these interconnections. Wealth, therefore, is a crucial fulcrum. To begin our discussion about the biology of adversity, let's take a look at what is called the discrimination iceberg. Racial and ethnic discrimination is an all too common form of adversity, and this illustrates an important example of an interconnection between adversity and cardiovascular disease. About 1/3 of discrimination is readily observable or overt, like hate crimes, but 2/3 are like the dangerous majority of an iceberg. They're covert, hidden below the surface. They include structural racism and implicit biases. Research shows significant associations of everyday discrimination with surrogate biomarkers of cardiovascular disease, such as elevated C-reactive protein levels, coronary artery calcification, hypertension, as well as low birth weight, poor sleep, and outcomes such as cognitive impairment and mortality. So what is the biology of adversity?
Multiple chronic life course psychosocial stressors affect individuals to varying degrees, including financial hardship, discrimination, relationship stress, structural racism, and others. Genetic and epigenetic factors and maladaptive behaviors interact with these stressors. Acting through the brain, these psychosocial stressors can lead to 3 physiological maladaptations: heightened inflammation, dysregulation of the hypothalamic pituitary axis, and dysregulation of the autonomic nervous system with upregulation of sympathetic activity and downregulation of parasympathetic activity. Together, these maladaptations drive allostatic load, which in turn drives progression of multiple pathological derangements, including metabolic conditions, cardiovascular conditions, and accelerated aging. Like falling dominoes, life course adversity stressors culminate in a causal chain that leads to serious metabolic, cardiovascular, and other untoward health outcomes.
The biology of adversity can also have an intergenerational link. Take the example of a pregnant person. Biological effects may be passed on to her children via epigenetic mechanisms. Adverse maternal experiences, such as depression, economic issues, and social status, can lead to poor cognitive outcomes as well as cardiovascular disease. Remember the ACEs we talked about? Well, the most common ACE experienced is economic adversity. And this type of ACE is experienced across the life course. I believe economic adversity is a root cause of health inequities and disparities. Economic adversity is an international phenomenon. The top 1% of individuals have nearly 20 times greater wealth than the bottom 50% of the global community. In the United States, many jarring statistics illuminate a marked wealth gap by race and ethnicity. Clearly, this makes the playing field uneven and economic progress nearly impossible because it limits intergenerational wealth and health. You might be thinking that education can help bridge this gap, but it's not that simple. While education does increase wealth, the returns are not the same for everyone. Black persons need a postgraduate degree just to attain similar wealth as white individuals with a high school degree. As that sinks in, let's hear again from Barbara and Akane.
We first met when I took care of you when you were hospitalized with cardiogenic shock. I know that you have been concerned about the stresses in your life related to not having secure housing and your finances and just the change in your life. Could you just tell me in 2 sentences, sort of how profound that's been for you?
Well, it's been very profound because you never know from one time to the other whether things is going to work out okay. Makes me feel like I worked 45 years to be disappointed, and now I got to be 81 and I can't work. Section 8 to a certain extent, and anywhere else if I lived what's called open market value, this apartment right here would be $3,200. I can't afford that. I don't make that much in my pension, and I'm just out of luck. And that's a stressor in itself, unnecessary stress.
I became ill. I was a public high school teacher. I had, a good life. Because of the delay in my diagnosis, ultimately I ended up having to resign from my job. I was really in a financial pinch, created so much anxiety because part of my illness is like profound fatigue, and just even the thought of losing my home, since anxiety affects all aspects of your body, including the hormones, which I have issues with. It was very debilitating. Luckily, I have Medi-Cal. Thank God for Medi-Cal, because without it, I wouldn't have any insurance.
So patients like Barbara and Akane tell me all the time, don't let me die because I don't have enough money. This is why I believe we all have a role to play. So what does the data tell us about financial strain or economic adversity of our patients? About 12% of people have difficulty paying medical bills. This includes 20% of middle-income people. The percentages are even higher for younger persons as well as low-income individuals. And we as health professionals are also not immune to economic distress. Research from our Nurture Center team looked at female health professionals with 3 or more financial strain events. We found that they had a 77% lower odds of ideal cardiovascular health compared to health professionals without financial strain. The burden of this is best described in the words of James Baldwin, quote, "Anyone who's ever struggled with poverty knows how extremely expensive it is to be poor," end quote. Now, I will bring up a concept that may modify the way we think about intervening to reduce economic adversity. It is called the diminishing returns hypothesis. This hypothesis asserts that vulnerable racial and ethnic groups do not experience the same returns as white people from resources such as education. In fact, the greatest racial and ethnic differences are from among children from the wealthiest families. This diminishing returns hypothesis is also observed in Medicare beneficiary data, showing that post-myocardial infarction life expectancy was shorter for Black individuals compared to white individuals. And this life expectancy gap was largest among Black individuals of higher socioeconomic status compared to the equivalent socioeconomic status of white persons. At a biological level, the diminishing returns hypothesis is supported by a study from Detroit, looking at the effect of neighborhood socioeconomic adversity on biological aging. It uses telomere length as a marker of health outcomes. Simply put, the longer the telomeres, the better. The results are striking because of the differences across racial and ethnic groups. Interestingly, Black women who lived in poor neighborhood environments had similar telomere lengths as Black women who lived in non-poor neighborhood environments. Not everyone who experiences adversity will experience poor health outcomes. To understand why, let's take a look at the taxonomy of psychological stress, a core component of adversity. Positive and tolerable stress are both associated with healthy brain architecture. For example, under the heading of positive or tolerable stress, you could include writing a grant or delivering this presentation. Then there's toxic stress. Toxic stress, such as stress caused by unrelenting lifelong discrimination and economic adversity, is markedly deleterious, especially in the absence of adequate social and emotional support. It is exacerbated by chaos, abuse, and neglect. It is associated with unhealthy brain architecture. But how can we move from toxic stress to more tolerable stress, especially in our efforts to reduce economic adversity and its health effects? One of the main messages I hope you take from this address is that this powerful shift is possible. I believe solutions can be found by increasing resilience and employing novel and creative interventions. For example, we can maximize resilience at a societal level by providing access to counselors or organizations who can facilitate supportive relationships, and by building a sense of self-efficacy and perceived control. Resilience can also be enhanced by providing opportunities to strengthen adaptive skills and self-regulatory capabilities, as well as by mobilizing sources of faith, hope, and cultural traditions. Resilience can be increased at any age. Perhaps the concept is best expressed in these words from a personal source of hope, strength, inspiration, and optimism. Maya Angelou, she said, quote, "I can be changed by what happens to me, but I refuse to be reduced by it." End quote. I want to empower you to see yourself as part of the solution. You can be part of the movement towards ensuring education and employment in a way that will improve generational wealth and health. It starts by committing to make a difference. We need not let people die from the effects of economic adversity. You can make a difference by supporting innovative ideas. One example is the policy concept of baby bonds, a creative intervention designed to close the wealth gap. If this were a policy in the United States, the government would establish a trust fund for every American newborn, the amount determined by the family's socioeconomic status. The money would be accessible at age 18 for wealth-generating reasons, such as education, building a business, or home ownership. You can make a difference by seeking non-traditional partnerships. Wealth-generating entities such as banks and other financial companies can team with nonprofit organizations or community-based groups to address social factors in order to improve chronic disease outcomes. Having financial companies involved is especially significant. Given the history of redlining and predatory lending that have disadvantaged communities of color, it is time for those who have been traditionally omitted from the wealth-building process to have significant opportunities from more financial companies. You can make a difference by having your health system embrace the concept of 5 A's, laid out in the 2019 report from the National Academy of Medicine about integrating social care into the delivery of healthcare. The 5 A's are awareness, adjustment, assistance, alignment, and advocacy. Adjustment and assistance are focused on individuals, whereas alignment and advocacy are focused on our communities. Awareness, of course, covers it all. Under the heading of adjustment, some have provided and deployed mobile units to reach people where they live to deliver preventive health services. You can make a difference by turning your healthcare institution into an anchor institution, not just for your patients, but for your entire community. This means investing in the social and economic development of your community. UCSF and Rush, located right here in Chicago, are examples of institutions doing this. They support community workforce talent development, employment opportunities, and financial readiness. You can also encourage your healthcare system to provide medical legal partnerships. Having attorneys at the ready can help patients, especially low-income individuals, address legal stressors such as those related to unhealthy housing, income, immigration, and disability. That would help my patient, Ms. Tops, by the way. If you're a clinician, you can make a difference by helping understand and address adversity in your patient care. When you assess a patient, incorporate an evaluation of financial well-being along with other social factors. You can capture socioeconomic adversity by using something like the MacArthur Social Status Scale. This scale allows self-reporting of social status using a ladder format. It has better predictive capacity than objective measures like income and education in ethnically and socioeconomically diverse populations. Another option is making someone on your team a social navigator, a job that goes beyond traditional social work. This person would connect patients with support systems like legal services, as well as help with finances and other types of adversity. I also encourage you to use the Healthcare Provider Cultural Competency Instrument. It can potentially help attenuate disparities by its focus on patient-centered care. Additionally, the 2019 ACC/AHA Primary Prevention Guideline for Cardiovascular Disease outlines social determinants of health considerations that you can assess within risk factor categories. If you're a researcher, you can make a difference by incorporating into your work economic and other social measures. Better still, Do this while partnering with community organizations. All of this is especially true for those in translational, clinical, and implementation domains. If you're a basic scientist working with animal models, look to co-design projects with translational researchers. For example, as part of my AHA-funded Merit Award, our UCSF Nurture Center has developed a novel clinical trial in partnership with the YMCA of San Francisco. Our SCULP job study incorporates job readiness and legal services into a weight wellness intervention for socioeconomically disadvantaged people. You can make a difference by being an advocate at the local, state, national, and international levels. Your patients suffering the health effects of economic adversity are rarely heard by those in power. You, however, are a respected professional. So make your voice heard by speaking out in support of state policy issues, such as the critical need for additional Medicaid expansion and federal efforts like the No Surprises Act. If you want to help, contact your local AHA office. You can make a difference by also getting involved in your local school system. If it is not racially or ethnically diverse, ask why. Act on solutions towards diversification racially, ethnically, and socioeconomically. And finally, you can make a difference by serving as a mentor or sponsor of diverse people from across the world. We have all benefited from our mentors and sponsors. We need to pay our experiences forward by being intentional about expanding our reach. It is critically important in addressing health equity and in dismantling structural racism in science, medicine, and society at large. To sum it all up, I would like to share another quote that inspires me from a man who's inspired generations, the Reverend Dr. Martin Luther King Jr., who said, quote, "The greatness of a person cannot be seen in the hours of comfort and convenience, but rather in the moments of conflict and adversity." It has been my deepest honor to speak with you today. I owe sincere gratitude to God, my mentors and sponsors, especially Mike, Paul, David, Judy, Peter, Julie, Elliot, Victor, Gary, Jonathan, Amelia, Talmadge, and Catherine. My mentees, colleagues, and friends, and most importantly, my family, who understand the lived experience of this presentation. Michael, Caroline, Marion, Charles, Ben, Maxine, Valda, Aubrey, Carmen, Audrey, and Ed, the love of my life. And now, I leave you with images of the deep pipeline of young people who inspire me. I hope they inspire you too, to be more aware of the burdens faced by too many, to make a difference, to help stem the tide of economic adversity. Thank you.